Good evening, everyone. Thank you all for joining us tonight. I'm Hannah Collins, and we're here with Dr. Lewis discussing managing gallbladder disease. I'm going to go ahead and give y'all his bio, and then he can go ahead and get started. Dr. Lewis earned his medical degree from the Medical College of Georgia in Augusta. He completed his internship and residency in general surgery at the University of Tennessee Medical Center in Knoxville. Dr. Lewis is a member of the American Medical Association and the American College of Surgeons, and he is certified in advanced cardiovascular life support, fundamentals of critical care support, and advanced burn life support. So give it up for Dr. Lewis. I'll let him go ahead and take the floor.
Thank you, Hannah. Thank you guys so much for attending this event. I know it's a little bit different, but probably kind of nice to be able to watch this from home. So today I'm going to talk a little bit about gallbladder disease. I'm going to try to keep it somewhat succinct. I think we have the ability for people to ask questions, particularly if we have a smaller group. We can ask questions as we go along, so we don't have to wait till the end. And maybe Hannah, you could talk about that. But we'll go ahead and get started. So the objectives of today, basically what I want to do is provide a good general overview of why you need your gallbladder removed. And in order to really understand that, it's important to understand how the gallbladder works, what is its function, and what can go wrong with it. So we're going to get into a little bit of the broad overview of what it does. Essentially, what is the gallbladder? The gallbladder is a storage unit that stores bile. And what is bile? Bile you can think of as simply as like a soap, and it aids in digestion, particularly in fat and greasy things that we tend to eat. The gallbladder stores this bile until it needs to release it into the intestines to aid in digestion. And essentially what happens, I'm going to jump forward a couple of slides so you can see the gallbladder, it rests on this sort of the undersurface of the liver, and there's an organ sort of centrally right there, and I don't know if you guys can see the fine print here, but the pancreas will send a signal to the gallbladder which tells it to squeeze and effectively secrete the bile that's contained within it, and that aids in digestion. This occurs, particularly again, like we said, when you eat fatty foods, greasy foods, sometimes spicy foods. Okay, so a little bit about its anatomy. Again, it's in the right upper quadrant on the underside of the liver. It's connected to both the liver and the GI tract through a series of ducts. And we can think of this, and I'll flip forward again, as sort of the plumbing of the biliary system. Essentially, bile is produced and made, as we call it, conjugated within the liver, and it forms as a breakdown product of our red blood cells. The bile travels through these small, and on your screen it should be some greenish colored ducts, and that's sort of the piping as it goes from the liver into the gallbladder. And then when we eat that fatty meal, the gallbladder squeezes to release it. It travels through its own duct called the cystic duct down into the common bile duct and back into the intestines. Okay. And that's essentially how the gallbladder functions and how it works. So now we're going to get into kind of a little bit of the things that can happen, the problems that can happen with the gallbladder. And the most common one that we see and that you probably hear about is gallstones. And the gallstones prevalence within the United States is actually quite high. Here on this slide, it says up to 20 million citizens are affected by gallstones. I've read in textbooks up to 30 to even 45 million people in the United States. So effectively, you could think about it, 1 in 10 adults, or about 10% of the country, we believe has gallstones. Now, just because gallstones are present doesn't necessarily mean you'll ever have a problem. It doesn't mean you necessarily need surgery. And we'll get into kind of the indications for that a little bit later. So how do these gallstones develop? Well, there's different types of gallstones, but by far and large, the most common type of gallstone is produced from concentration of cholesterol. And these gallstones, they can cause a variety of problems. Like we said, a lot of people have them, but really of those, 20 to 30 million or so people who have gallstones, really only about 20% of that population of people has symptoms of gallstone disease. And it's only when we develop these symptoms or other issues or complicating factors of gallstones that we need to look into maybe removing the gallbladder to prevent these things from happening. So some of these things, and these are some of the terms that you're going to hear a little bit more about: cholecystitis, which is inflammation or infection of the gallbladder that can happen from gallstones; choledocholithiasis, that's when these gallstones are of a certain size and they actually can tend to migrate through the bile ducts, sometimes getting stuck in the bile ducts and causing other issues; and pancreatitis you've probably heard of. It can be quite severe, can lead to hospitalizations. And the most common cause that we understand for pancreatitis is actually for these gallstones traveling and passing through and by the pancreas. This is just a little slide and a picture of some of these pathologies going on. Gallstones come in a variety of shapes and sizes. Some of them can be quite large, and I'll show you a picture a little bit later of a really big gallstone. Those big gallstones tend to sometimes obstruct the gallbladder and they can cause cholecystitis. These smaller gallstones, as pictured here, they tend to migrate and they can travel through not only the cystic duct, the small duct from the gallbladder itself, into the common bile duct there, and you can sort of see where they get caught. They can get caught right there, traveling into the intestines, right at what we call the ampulla. They can block up that pancreatic duct and eventually lead to pancreatitis or something else that we call cholangitis, which can be much more serious. So what are the common symptoms? And these are kind of listed almost in order of what you would see. The classic symptoms of gallstone disease is going to be abdominal pain in the right upper quadrant. It can radiate or move to the back on the right side or the shoulder, usually on that right side. Pain can sometimes be in the center of the abdomen. Some people will come in describing chest pain, or they think they may be having a cardiac issue. So it can kind of vary on its presentation, but in general, the most common way to know is if right upper quadrant pain is present, and it often happens after you eat something. If you think about it, go back and how the gallbladder works, when we eat fatty or greasy foods or spicy foods and stimulate that gallbladder to squeeze, it squeezes on those hard stones. And if those stones get stuck, particularly at the neck of the gallbladder or close to where the cystic duct is, that will oftentimes cause pain. What does the pain feel like? It can be sharp or dull, kind of stabbing feeling. It can last anywhere for a few minutes to several hours. Okay. Some other symptoms, as you'll see here, that you might have: nausea. Sometimes people have a great degree of nausea and even vomiting associated with this. Some of the more atypical symptoms: bloating. If it gets more severe, then you could have things like fever or chills, and that kind of goes into the realm of cholecystitis. Some of these things listed here: clay-colored stools and yellowing of the skin. That goes back to the previous slide where we can see these stones getting stuck in the bile duct. And when the stone gets stuck in the bile duct and doesn't allow any of that bile to move naturally out of the biliary system, that bile can back up, and that's what the yellowing of the skin or jaundice can be caused by. That's one of the ways that can develop. And the clay-colored stools, that can happen as well, because that's what gives the brown coloration to our stools. So this is getting into another one of the pathologies that can happen with the gallbladder. So aside from symptomatic gallstone disease, people can sometimes develop what we call a motility disorder of their gallbladder, or a functional gallbladder disorder. This is more rare, but we are seeing it, and I think I'm seeing a little bit more commonly now. In general, the term that we describe as a functional gallbladder disorder is biliary dyskinesia. And what does that mean? That means that the gallbladder, if you go back to thinking about its function, it's designed to squeeze and secrete bile. And in certain instances, particularly in patients who have typical pain symptoms of gallbladder disease, right? So right upper quadrant pain can happen after you eat that fatty meal. It may have some associated nausea or bloating. if they have that typical symptom and they get worked up and say we discover that that patient doesn't have gallstones, but they have very typical biliary type symptoms and we're very suspicious of the gallbladder, we can do another test that helps figure out if a functional gallbladder disorder may be causing that problem. That test is called a HIDA scan. So what the HIDA scan does is it stimulates the gallbladder and it allows us to visualize the passage of bile through the biliary system in and out of the gallbladder and see how efficient that process is. And the term biliary dyskinesia essentially means that the gallbladder should be ejecting or secreting at least 70 to 65% of its bile. Okay, if it doesn't, and on the HIDA scan the ejection fraction is less than 35% or so, then you may be termed as having the diagnosis of biliary dyskinesia. And again, oftentimes that'll give you the similar symptoms of having gallstones without the stones being present. And oftentimes that can lead to further surgery as an indication to get it removed. We're talking about other functional gallbladder disorders. You may hear terms such as hyperkinesia, and that's a term that's somewhat more controversial in nature. And we don't recognize it completely in our surgical literature yet, but there's some theory to say that people who have a high functioning gallbladder, say their ejection fraction is 95% or higher, it may certainly lead to other similar symptoms. Basically, what it comes down to is if you have typical biliary symptoms and a complete exhaustive workup, meaning we can't figure out what's going on, what's causing that typical right upper quadrant pain after you eat a fatty meal, and you've had a series of tests, CT scans, ultrasounds, HIDA scans, and even say you have a normal functioning gallbladder, sometimes it's indicated to go in surgically and remove it to help prevent that problem from continuing to occur. But again, that would happen after a very exhaustive clinical workup and usually through several different subspecialists. So we're going to talk a little bit more about some of the more complicated things that can happen with the gallbladder, not just gallstones. The most common form of complicated gallbladder disease we see is called cholecystitis. And cholecystitis essentially means that your gallbladder, most commonly secondary to having gallstones, has become obstructed. And it generally, in the early stages, becomes very inflamed, distended. On imaging studies, we'll oftentimes see fluid around the gallbladder, thickening of the gallbladder, and this can lead further to more of a bacterial involvement. Usually early stages, it's somewhat of a sterile process, but later stages it can certainly have a bacterial involvement, and antibiotics could certainly be of help. Generally speaking, we want to operate on these people when this happens early, so within the first 72 hours of the symptom onset. Usually these symptoms are long-lasting, so with your typical biliary colic or symptomatic gallstone disease, it may last for a few hours and get better on its own, but cholecystitis tends to stick around a little bit until the gallbladder's obstruction is relieved. We see cholecystitis in a variety of forms in patients. Again, usually it's caused from gallstone disease, but sometimes in atypical forms. We see it in what we call acalculous cholecystitis, or in people who don't have gallstones. And oftentimes it's associated with other medical illnesses that are going on. We can see this in people that are hospitalized for other conditions. And sometimes in those situations, it's not safe to remove the gallbladder, and we may have to place a drain within the gallbladder and take it out at a later time. Some of the other terms that you see on here, cholangitis and biliary pancreatitis, which we had briefly mentioned before, these occur after the passage of the stones, again, through that common bile duct, and oftentimes result from those stones becoming entrapped within the common bile duct. Generally speaking, we don't go in and operate immediately to take care of these issues. Oftentimes we involve our GI colleagues who have the ability to go in with a scope through a procedure called an ERCP, and those guys can go in and actually sweep the stones out of the duct and clear that process from within the bile ducts. And usually we like to take the gallbladder out during that hospitalization to prevent those problems from happening again. And we'll kind of glaze over these other issues, which are much more rare, but sometimes gallstones can lead to other problems. They can become big enough to compress the bile duct. That's called Morizzi syndrome, and gallstone ileus. If the gallstone actually is able to move into the intestines and it's big enough, it can cause an obstruction. But again, those are very rare issues that we don't see very often. So you may ask yourself, okay, well, how do I prevent this from happening? Again, if you have gallstones already, it's not necessarily an indication to get surgery unless you begin to have those symptoms of classic biliary colic that we talked about. If you already have stones, there's really no way that we know of to get rid of them. There's no dietary measures that will help get rid of those stones. But in general, preventing them on the front end is just being healthy overall, not gaining a lot of weight, being active, and eating a good balanced diet. So let's get into a little bit of the treatment, and this is what we do. Again, this surgery for gallbladder disease is very common. Here on average, our surgeons do anywhere from 100 to 150 a year. It's probably the most common surgery that we do as general surgeons. And again, the indications for surgery are symptomatic gallstone disease. So not just the mere presence of those gallstones, but when those gallstones start causing you problems. That's when you need your gallbladder removed to prevent further complicating things from happening and to get rid of those symptoms. If you get complicated gallbladder disease such as cholecystitis, or you have a history of biliary pancreatitis, or if you have a functional gallbladder disorder, and the functional gallbladder disorder is really if you have that classic pain and it seems very much like your gallbladder, that's generally the patient population that is of most benefit to gallbladder removal. So this picture kind of shows a couple of the different ways we remove the gallbladder. The typical standard of care now for gallbladder removal, and the term that we use for that is called a cholecystectomy. But the standard of care is to do it actually laparoscopically. And what does that mean? A laparoscopic procedure is something that was developed to create smaller incisions, increased return to work time, and really a shorter hospitalization. The old-fashioned way to remove the gallbladder is called an open cholecystectomy, and that's where we make a larger incision just below the rib cage on the right. Oftentimes those patients require an inpatient hospitalization, staying in the hospital for a few days because the recovery is much greater. The procedure now being done laparoscopically, as it has been really since the early 90s. It's a much quicker stay in the hospital. Actually, it's what we call one of our ambulatory surgeries, meaning you come in the hospital, usually your procedure is done that morning and you're home by that afternoon. The laparoscopic procedure entails very, very small incisions, anywhere from 5 millimeters to 1 centimeter in size. The way I perform the surgery is I do 4 of those incisions. But I've seen this done through 1 incision called a single incision cholecystectomy. I've seen surgeons do it through 2 or 3 incisions with aid of other devices. But in general, most of us do this with 4 small incisions, and we insert a very small camera into the abdomen. The abdomen gets what we call insufflated, meaning we instill CO2 gas within the abdomen to inflate it, so it creates this large space where we can see and effectively operate and stay away from other structures. We use these small instruments to dissect out the gallbladder to really delineate its anatomy in a safe way and remove it from the abdomen. One of the questions I get asked a lot in clinic is, can you just take the stones out and leave the gallbladder? And the answer to that is simply no. And even if we were able to take the stones out, that wouldn't prevent them from happening again. These are just some of the pictures from surgeries that you can see on your screen there far to the left. This is sort of what we see when we do a laparoscopic procedure. And as you can see, it doesn't really look like some of those earlier pictures we were showing you of the anatomy. Sometimes it takes us a great deal of time, particularly in cases where people have cholecystitis or a great deal of inflammation around their gallbladder. It's a very tedious dissection. This area of the body, it's high stakes real estate. There's a lot of important structures in this area, so we really take our time to do a very careful and tedious surgery to get the gallbladder out safely. So that brings me to some of the risk of surgery. What are some of the risks? There's some risks that are inherent to every surgery, like bleeding and infection. And those are relatively low for gallbladder surgery. The one we tend to worry about the most with cholecystectomy is injury to other structures in this area, such as the common bile duct or the first portion of the small intestine or the liver. Again, these risks are somewhat low, about 1 in every 300 cases, and they go up higher in cases of severe inflammation or disease that has been somewhat neglected. So we've already covered this in some detail already with laparoscopic cholecystectomy, and I'll touch on robotics. Some of us also do robotic surgery, and we can certainly take the gallbladder out robotically. And you may be asking yourself, well, what's the difference in who should be receiving a robotic surgery versus a laparoscopic surgery? And that's somewhat of a controversial topic too, and it really depends on your surgeon and what they do the most of. And in certain cases, such as myself, I do offer the robotic gallbladder removal, and I find it more beneficial in cases where people are more obese, because the robot allows us to manipulate the liver, which can be quite heavy. Sometimes we can see better and identify anatomy a little bit better with the robot. But for the most part, a laparoscopic procedure in my hands is a little bit more efficiently done laparoscopically. But again, robotics is always an option, and some other surgeons may be more efficient at doing the robotic surgery up front. Robotics also gives us the ability to use a green dye that we call ICG that can also help us safely identify anatomy during that procedure, particularly if it's difficult. And the gallbladder anatomy you can kind of see to the right, and all the green is illuminating the different bile ducts as they connect to the gallbladder and traverse away from the liver. So a little bit about what to expect with surgery. Again, this is an outpatient procedure most commonly. We do perform it in an inpatient setting when people have episodes of cholecystitis and they need to be hospitalized for that, or again, if people have more serious or complicated gallstone disease like gallstone-associated pancreatitis or cholangitis. But generally, this is done on an outpatient basis, and you'll come in early in the morning. You can't have anything to eat or drink after midnight the night before. This is a surgery that requires a general anesthetic, so you will be placed completely asleep. After the surgery, you go to a recovery area, and usually after an hour or two, you start drinking, start ambulating and moving around, and one of your family members or friends takes you home at that point. What to expect in the weeks to come. Generally, people, it takes a couple of days to recover. Pain can be variable. You're, of course, going to be sore after having the surgery. Again, it kind of depends on the degree of gallbladder disease you had going into the procedure as well. I have pretty minimal restrictions after surgery. You may be asking, one of the more common questions you get is, when can you return to work? I don't tend to limit people from work any more than a week after this surgery, unless their work requires them heavy lifting. And if it's possible for them to go to light duty, we'll do that. It's best to limit my patients from lifting 15 to 20 pounds for about 2 weeks. And that's generally the biggest restriction that I have after the surgery. Another common question I get is how do I need to alter my diet, or what can I eat, what can I not eat? And it really just sort of depends. It's one of the things where a lot of times the fatty foods that may have been causing the symptoms of gallbladder pain to begin with may still give you issues after gallbladder removal. Now, it shouldn't give you similar pain, but oftentimes the fatty foods can cause somewhat of an upset stomach and other issues such as diarrhea. That's more of a more common ones that we see is about 10% of people after gallbladder removal can get diarrhea, but that can be mitigated with not only controlling the diet, but sometimes if it's more consistent, we can give people a medicine that helps bind up the bile and help prevent that from happening. So with that, I think we'll take any questions you guys may have.
Dr. Lewis, you did have a couple come through.
Okay.
One of the first ones that you had was, what is the quickest way at home to relieve gallbladder pain?
Yeah, you know, that's tough because it sort of depends on what's going on, and it's hard for you to know while you're at home, right? If it's severe pain, if you have fever and your pain isn't controlled with simple over-the-counter medications such as Tylenol or ibuprofen, then you may need to come to the emergency department, particularly if it's severe and not getting any better after several hours. In general, avoidance of those fatty foods and things that could exacerbate it is really the best thing to do. If you do have that pain, you really need to call our office and get seen or talk to your primary care doctor to have us evaluate you. You know, and like I said, it can eventually get to the point of a more serious gallbladder issue like cholecystitis, in which case, you know, your pain's not going to go away. But most of the time, it will go away after a couple of hours, if that answers your question.
Okay, and another one you had was, is there a specific food group that causes your gallbladder to flare up?
Yeah, in general, if you want to talk about food groups, it's anything that's fried, that's greasy, that's cooked with a lot of butter, a lot of oil. That's going to really stimulate the pancreas to secrete CCK, which causes the gallbladder to squeeze. And if you have stones or functional gallbladder disorder, that's when you're going to start to have problems. Now, I will hear anecdotally from other patients that spicy foods will often cause similar symptoms. And believe it or not, you know, you may have problems with your gallbladder and think, well, I'm going to eat really healthy and I'm going to eat a salad. And for whatever reason, sometimes, you know, salads can cause people to have similar right upper quadrant pain and gallbladder issues. I'm not quite sure why that is, other than maybe it's the, you know, greasy type oily dressings that we use, or maybe the gallbladder just doesn't like salads, who knows.
Okay, and somebody else asked, are there ways to flush out your gallbladder?
From a medical standpoint, no, not that we know of. You will read things, particularly on the internet, about gallbladder cleanses and gallbladder flushes. You know, there may even be chiropractors that say that they can help with your gallbladder pain. In general, there's no medical science that we know of that backs any of this up. Some of these things certainly might not be dangerous to try, but again, we don't have any data or anything that we know of in the medical literature that says you can flush out your gallbladder. And truthfully, you know, the terminology of flushing out the gallbladder, you know, it may not be necessary. You know, if you have stones in your gallbladder, you know, if they're not causing you problems, you don't need to have anything done.
And another question that just came through was, are there other requirements to being able to receive robotic surgery?
You know, again, it's kind of dependent upon the person and the situation with the particular surgeon that they're seeing. One of my partners, he prefers to do robotic surgery in the majority of his patients. There's about half of our practice, I think, does the robotic gallbladder surgery. Again, I offer it more to people that are in the higher obesity category because I find it helpful to me as a surgeon to be able to manipulate the gallbladder and perform a safer surgery sometimes in those settings. But it's somewhat of a controversial topic in that there's no real concrete indication for a robotic cholecystectomy other than the surgeon's preference. And again, at my stage right now, I still prefer to do it laparoscopically because it's far quicker that way. It does take some time to set up the robot and manipulate the robot and then taking the robot down when you're finished. So in and that's why I say in my hands, it's a much more efficient procedure done laparoscopically and not robotically. But certainly there's other surgeons that are very, very quick with the robot because that's all they do. So it's really a question to kind of talk about with your surgeon when you come in for your preoperative evaluation.
And Dr. Lewis, are you and your team currently taking new patients?
Absolutely.
All right, well, that concludes our online webinar tonight. Dr. Lewis, thank you for joining us.
Thank you so much.
And everyone, please continue to check out our classes on tanner.org on classes and events for other informative topics that we have coming up. And I hope everyone has a great evening.